Welcome, everyone, to the People's Health Briefing, a key component of our Trusted Voices campaign. I'm Dr. Noha Abalada from Roots Community Health, reporting for the week of March 31st, 2025. As health professionals rooted in Oakland, serving some of the most marginalized communities in California, we're here to cut through the noise and bring you the latest information on health issues relevant to us all. I wanted to take a moment to say thank you to everyone who participated in our survey. We have selected and heard back from our 3 winners, and your Clean 360 soap baskets will be making their way to you shortly. And to everyone who participated, thank you so much. The insights we gained were very valuable, and we will plan to share some of those with you next week. In today's briefing, after an update on flu, COVID, H5N1, and measles, we will shed some light on vitamin A and measles. Starting off with respiratory viruses, this is the percent positive of each of these different viruses based on tests performed in a clinical setting. And influenza in the bright blue line continues coming down nicely. We expect it to continue to do so. And as flu's share of cases comes down, the share of others is coming up, including rhinovirus, enterovirus, the cold viruses in the gray, and human metapneumovirus in the black. The others are pretty steady or coming down. And now taking a look at hospitalizations from the main 3 respiratory viruses causing hospitalizations, flu, COVID, and RSV. And we can see that there was a peak of hospitalizations in early January from all 3 of these viruses. And then flu kind of had a second peak there in early February, whereas COVID and RSV have been coming down ever since they peaked in early January. We would anticipate flu in the blue line to keep coming down and likely cross over and go below the orange line, which is COVID. So this is just something we'll keep an eye on. The good news here is that there doesn't seem to be any indication that we will experience any more flu peaks this year or this season. And of course, we're still seeing flu cases and hospitalizations and death, but I think we can expect those all to continue coming down for the season. So far this flu season, we've seen about 44 million flu illnesses, 580,000 flu hospitalizations, and 25,000 flu deaths, including 159 pediatric deaths. And taking a look at deaths from all 3 of the respiratory illnesses, flu, COVID, and RSV, if we look out towards the right, we can see that for the first time in the pandemic, the flu deaths in the blue began to exceed COVID deaths in the orange. That started the week ending January 25th, and it's been happening each week from then until March 15th so far. So something we'll continue to keep an eye on. It'll be something to note whether this will turn out to be the case every respiratory virus season or not. It'll just be something we'll pay attention to. But until the next flu season, we would expect to see flu deaths come down to just about nothing, while COVID deaths continue at some level or another. So we'll talk about that more in just a moment. So basically, we expect to see flu and RSV come down until next season. So what about COVID? Well, we've been seeing at least 2 peaks a year, sometimes 3, and each year has been a little bit different, but let's see if we can try to identify any patterns. And for that, I'm going to share my screen. Taking a look at wastewater nationwide, we can see that it's generally coming down in all regions. And I thought we could take a look at the wastewater results since they started sort of reporting them this way. And this was back in winter of 2022. And these are all the regions. So you can see that each of them peaks at slightly different times and at slightly different levels. But if we wanted to just take a look at the average nationally, you can kind of get a sense of what's been going on year after year. And we can see that this was our wintertime peak in 2022. That was in early January. And then we had another peak here in July of 2022, so the summer 2022 wave. And then the winter of 2023. Well, this is actually technically December 31st, 2022, but that following winter, just slightly higher than the peak the summer before it. Then we kind of had a fall peak in 2023, followed by a winter peak in January 2024. And then we all remember last summer where we saw a lot of SARS-CoV-2 infections, and that peak was in August of 2024. And then we can see by comparison, this past winter peak, which was also early January, was smaller than the summer before it. And that was really the first time when the winter peak was smaller than the summer before it. So we'll just wait to see what is going to happen this coming summer and in years to come. But this general trend seems to be coming down, but every year something a little different. As we saw, we had that fall peak one year, and the time of the peak is slightly different, especially the summer peak, but the winter peak seems to be early January. And this is again in terms of how much of it is in the wastewater, which does not by definition correspond to cases and illnesses, but generally speaking, that pattern does seem to hold. So we don't exactly have an apples to apples comparison of wastewater trends and hospitalization trends, because remember that the current reporting requirements for COVID hospitalizations began this past November. So this is something we'll continue to keep an eye on, since we do anticipate that those reporting requirements will remain in place. But in general, what we have seen for the entire pandemic is that deaths lag behind hospitalizations, which lags behind cases, which lags behind wastewater. And as we know, we really don't have any reliable indicator of cases anymore. So we are mostly looking at wastewater hospitalizations and death. And when we do look at deaths, we indeed can see that during our summer peak, which is in the middle of the graph, this correlates to our summer peak of 2024. And we had 1,354 deaths the last week of August 2024. And so that was the most, whereas this winter's peak reached 1,030 deaths in mid-January and has been coming down ever since. So this is still too many deaths every week. We're now at just over 600 deaths the week ending March 1st. But hopefully we'll continue to see this decline week over week. But again, interesting that this winter peak was lower than the summer peak before it. But we know that these things are related. Since there was a lot of infection, there was relatively possibly more protection during this winter season. So this is just something to keep in mind as we move forward. Our lowest point ever in the pandemic was also actually last summer in June, where we got down to the mid 300s per week for several weeks. So I'm definitely hoping that that is a record that we can break this year. We still have a lot of work to do in terms of getting these numbers down. This is just us losing still too many people every single week from both COVID and flu. They continue to be significant causes of death in our population. And we could prevent a significant portion of these deaths by staying up to date with vaccination, as well as timely testing and treatment. And of course, timely testing and treatment are even more critical for those who aren't up to date on vaccination. But ideally, especially for those at high risk of a bad outcome, ideally we are doing all of the above, in addition to doing what we can to prevent transmission in the first place. And now for a brief update on H5N1. So the main risk to humans is still currently individuals working with cattle or poultry. So far in the United States, there have been 70 human cases. Of those, 3 were from an unknown source, which of course we don't like, but the majority are from known contact with an infected animal. Out of 70 cases, 38, so more than half, were in the state of California. There's been 1 death so far, that was in the state of Louisiana. We've heard some scattered reports around hospitalizations, but the majority of people seem to recover pretty uneventfully. So right now, while we're in flu season, there's a lot of flu testing going on through the National Flu Surveillance System. CDC is reporting that over 172,000 specimens would have detected H5N1 or any other novel flu A virus for that matter. Of those 172,000 tests, there have been only 6 positives that were detected, which is good and helpful information. The more targeted surveillance efforts surrounding animal outbreaks has been what has yielded the majority of our positive cases so far. So it will be interesting to see what happens when we get out of flu season and testing goes down. So we will be updating as we learn more. But in the meantime, once again, biggest risk is for people working directly with cattle or poultry. Those folks need accurate health information. They need proper PPE. They need up-to-date information on their industry standards or guidelines. And for everyone, we should be avoiding consuming raw milk and raw milk products. Don't touch any wild birds or any dead animals. Also try to keep your pets from doing so, and cook your meats thoroughly. And now for an update on measles. Our measles outbreaks in the United States continue. In particular, the one that began in West Texas is now spreading to multiple counties, as well as neighboring New Mexico and to Oklahoma, causing at least 444 cases so far. There are also outbreaks currently in Ohio and Kansas, as well as sporadic cases in several other states. So far, there are a total of 483 confirmed cases in the United States through March 28th. And last year, for the entire year, 2024, there were 285 cases altogether. So measles is off to a very strong start in 2025. And unfortunately, we have not seen any indication that it is slowing down yet. Thus far, 70 individuals have been hospitalized and there have been 2 deaths. I do think it's notable that 93% of cases so far this year are outbreak associated. By comparison, in 2024, less than 70% of cases were outbreak associated. So we can and do expect sporadic cases pretty much every year in the United States, but this many cases being associated with outbreaks is definitely concerning, because it means that measles is establishing itself with local transmission in several areas. And that makes it less predictable about where it's going to go next and what it's going to do next. And this has everything to do with vaccination levels in various communities. So if you have someone with measles who travels to a place with high vaccination rates, well, then it won't go anywhere really. It won't have an opportunity to really take hold and spread. But if that same person were to go to a community that has low vaccination levels, then it could create another large outbreak. So unfortunately, we're getting to a place of much less predictability, and things could certainly get worse before they get better. Some Texas officials are predicting that it could take a year to get through this outbreak. So far in 2025, 75% of the cases have occurred in children under 19. So that's represented by those first 2 bars put together. And it is especially worrisome that 157 cases, or about 1/3, are in children under 5. So remember, newborns would be protected by their mom's antibodies, if she has them, for the first 6 months of their life. And if for whatever reason mom did not have any protection, then neither would baby. And typically we aren't going to begin vaccination until after 1 year of age. So most babies from 6 months old until their first vaccination are very vulnerable. And then, of course, they don't get their second dose until they are 4 to 6 years old. So they are not fully protected until then. So this under 5 years old age group is actually rather vulnerable. I would venture to say that the vast majority of physicians in the United States have never seen or treated measles. And this is, of course, because of vaccination. But unfortunately, this appears to be changing, and it is really going to be important for physicians and other healthcare providers, and quite frankly, probably teachers and daycare providers and others, to get more familiar with it and get comfortable with it. Definitely a sad state of affairs to be going backwards like this, but here we are, and we're going to have to respond accordingly. I've linked a brief 6-minute video from the U.S. Department of Health and Human Services in the post. It's intended for clinicians, but it's pretty accessible. So anyone who is interested, maybe you work with children, maybe you work in a community with low vaccination rates, maybe you're a community health worker. It has a little bit of medical terminology in it, but it's relatively straightforward in case you are interested. One of the challenges with measles is that it can initially look like a lot of things with fever and cough and runny nose, fatigue, loss of appetite. So it won't necessarily be obvious initially, especially if you're not aware of exposure. But within a few days, the rash will appear, kind of a notable rash that starts up at the top of the head and works its way down the body. And it is associated with the fever. And in general, a person is most contagious 4 days before and 4 days after the onset of the rash. So it is really important to note the day on which the rash begins, because this is going to help with our efforts to do a few things to inform those who may have been exposed so that they can quarantine and also get medical help as needed. But it will also help us as we determine how to treat the patient, because it will help us determine how long they have had measles. And unfortunately, there is no antiviral treatment for measles. So we really have to do what we call supportive care. So things like IV fluids and stuff like that. But if we know soon enough, we can try what's called post-exposure prophylaxis. So after the person has been exposed, trying to improve their clinical course, we may try to provide some protection like an MMR vaccine within 72 hours of exposure, or immunoglobulin within 6 days of exposure. So it's a tight timeline, but it could improve outcomes. So another reason why it's so important to document when the symptoms start and when the rash starts. So just a reminder that measles can lead to respiratory failure, brain inflammation, permanent brain damage, blindness, deafness. It causes death in 1 to 3 per 1,000, even with the very best medical care. Also, it can wipe out parts of your immune system so that you become susceptible to other infections even after recovering from measles. Now, we know that MMR vaccine is highly effective at protecting you from getting measles, period. So nothing is 100%, but this is about 97% effective from 2 doses. And in general, this is thought to be protection for life, although we seem to be putting all of this to the test right now. So I'm sure we'll be learning more. But unfortunately, there is misinformation spreading that insinuates that vitamin A could somehow or is somehow working to treat measles patients. And this misinformation is unfortunately coming from the highest levels of government overseeing our health agency. So I thought it was important to discuss. Now, as a result of this rhetoric, West Texas is reporting a high demand of vitamin A and vitamin A containing products like cod liver oil. So this is very concerning, because unfortunately now there are reports of children in West Texas requiring treatment for toxic levels of vitamin A. Specifically, Covenant Children's Hospital in Lubbock, Texas is reporting abnormal liver function in some children that have been taking vitamin A for measles. So I think it's important to first say that there is no evidence whatsoever that vitamin A will prevent measles, whereas the vaccine series will prevent measles 97% of the time. So there really is no comparison to be had here whatsoever as it relates to prevention. But that is unfortunately some of what people are obviously taking from this misinformation that has been swirling around. But there are a few important things to note. First off is that vitamin A is very important to our immune system. And it is true that vitamin A deficiency compromises the immune system. So this is especially an issue where there is widespread malnourishment and nutrient deficiencies. So it is true that vitamin A deficiency is a risk factor for severe measles infection. And for that reason, the World Health Organization recommends that children with measles receive vitamin A for 2 days. So this is after diagnosis of measles. Now, there was a Cochrane review in 2005 that's often referred to. So I'll talk about it a little bit. It looked at randomized controlled trials in children with measles who were given vitamin A or placebo along with regular measles treatment. And these studies were analyzed to see if there was any benefit. 8 trials were included in the analysis. And when they looked at all of the studies together, which included over 2,500 participants, so when they pooled all of the results, they didn't find any significant reduction in the risk of death in the vitamin A group. However, they did find that 2 doses of vitamin A on 2 consecutive days in children with measles did reduce mortality in children under 2 years old and reduced mortality from pneumonia in this group of children under 2 years old as well. And there were no reported adverse effects from these 2 doses, which is important. Now, 6 of the 8 studies were conducted in Africa, 1 in Japan, and 1 in England. So this wasn't necessarily reflective of measles here in the United States, where we do not have an issue of vitamin A deficiency in general. Nonetheless, I think it is important to consider this data and important to note a couple of other factors. So first off, we will not necessarily know if a child is vitamin A deficient when they present to the hospital with measles. So it is rare in the United States to have vitamin A deficiency because most of us will get sufficient vitamin A from our diet. Vitamin A is found in milk and cheese and cereal, fortified cereals, which most cereals in the United States are fortified. Also eggs and leafy green vegetables, and also orange vegetables, and also fish, and also meat. So vitamin A deficiency is really not something that we tend to see in the United States. It's rare here. It's much more common in lower income countries where access to food, especially access to animal products, is much more limited. Now, having said that, there are all kinds of different diets and other conditions and things like that out there. So we won't necessarily know about a pre-existing deficiency of vitamin A when someone is coming in with an acute infection like measles. Secondly, it's important to understand that measles itself can actually interfere with our vitamin A levels. And there really isn't a great test that we can just do quickly to find out if a person is deficient in vitamin A. So there may be some room to do some additional work to improve in this area. But it is thought that infections in general can cause an impairment in a person's vitamin A status. And that is because, well, first, when you're sick, you don't eat as well. So that's one thing. Also, it appears that we don't absorb vitamin A as well or use it as well when we're sick. And it also appears that we excrete it more. So I think there's also more study that needs to be done on all of this, but it does point to kind of a two-way relationship where vitamin A deficiency can contribute to a severe measles outcome, and measles can impair one's vitamin A status. So part of the problem that we're facing is that because vitamin A deficiency is not a significant problem in high-income countries like the US, we have not done a whole lot of study on vitamin A and measles in this country. Now, we may have that opportunity now, for better or for worse, to look into this further. But in the meantime, it is recommended that all children diagnosed with measles should receive vitamin A supplementation, regardless of what country they live in. And the doses do vary by age. And of course, it's different if we're actually treating for signs of vitamin A deficiency. But even if we don't suspect vitamin A deficiency, we would still want to give the 2 doses of vitamin A, and the dosage is very important. Talk about that more in a second. And it is age dependent. So it's going to be different for an infant under 6 months, an infant 6 months to 11 months, or for children over 1 year. It's not completely clear how old this recommendation should go to in the United States, but remember that so far the only real time that we've established a benefit is under 2. But again, because there doesn't seem to be much downside of just the 2 doses, again, we'll talk about when people are doing this on their own outside of the treatment. But if it was just the 2 doses administered in a hospital setting as part of measles treatment, there's probably not a whole lot of downside. The benefits likely outweigh the risk in most cases, so it should be considered part of measles treatment. There have been some studies examining how well these guidelines have been adhered to, and it is quite variable, but many hospitals in the United States, it appears, have not per se been giving vitamin A, or they weren't giving a high enough dose of the vitamin A. Again, this is something we haven't treated very much in the United States, So it's not necessarily surprising, but it is something where we will need to improve, especially given the current situation we're in. So certainly if you have a child or know a child that contracts measles, then 2 doses of vitamin A administered by a physician. And this is something that you can certainly inquire about. But to be clear, what we should not be doing is giving it thinking that it is some kind of a preventive measure or that it is some kind of an alternative to the vaccine. It is neither of those things. It is simply part of the treatment regimen, which all people treating measles should familiarize themselves with now. And I've linked an excellent call to action in the post. It was published in 2020 by the National Foundation for Infectious Diseases that lays out a lot of this information and contains, I think, some important recommendations for the field, including additional research that we should do specific to the United States, as well as healthcare professional education about the role of vitamin A in managing measles, as well as understanding the risks of vitamin A toxicity. So, because there's unfortunately so much misinformation going around and people are taking matters into their own hands and taking vitamin A or giving it to their children, one important thing would be to take a good history from parents about whether they have been giving their child vitamin A before going ahead and administering it, because the last thing we want to do is exacerbate matters if we are in a potential vitamin A toxicity situation. So yes, vitamin A toxicity is definitely a thing. Vitamin A is one of the few vitamins that is fat soluble. So fat soluble vitamins can accumulate in the body and become toxic. So this is only the case with vitamins A, D, E, and K. All the other ones are water soluble, and any excess would be excreted in the urine. But vitamin A can accumulate, and if you take it in pregnancy, it can accumulate and cause birth defects in the child. Vitamin A accumulation can cause bone loss, it can cause hip fracture, and it can cause a lot of symptoms that could really confuse the picture if you've also got measles. So it can cause, or if you might have measles, so it also causes poor appetite, nausea, vomiting, diarrhea. It could cause liver problems. And certainly if you've got something like measles along with all these other symptoms, it can definitely confuse the picture, which is not helpful at all in a situation like this, let alone the fact that we could now be dealing with having to address a vitamin A toxicity situation in addition to having to support someone who's got an acute infection. So we do need more study. We possibly need some updated or more clear guidelines, but it does seem clear that at this time, based on what we know, children with measles should receive 1 dose a day for 2 days. That's it, administered by a physician. This is not something that parents or caregivers should be taking into their own hands, because you can cause more harm than good. So in terms of preventing measles, most important thing by far is the vaccine. Measles is so contagious and the vaccine is so effective that any other measures really do pale in comparison, but I'll mention them anyway, because they're certainly important for people who cannot take the MMR vaccine, or who have an immunocompromising position, or who don't mount a good response to the MMR vaccine, and also as it relates to all infections spread by the respiratory route, which is that we should keep up our best practices to prevent the spread of respiratory illnesses. And so in addition to staying up on vaccination, a high quality filtration mask like an N95 or a KN95, also doing what we can to gather in well ventilated spaces, especially or including ideally outside, but also we can pay attention to our indoor air quality, and we should be continuing to do what we can to improve indoor air quality. Also, at the earliest signs of any symptoms of infection, seeking care, getting tested, and doing what we can to quarantine, isolate from others so that we don't get others sick. So let's continue to stay informed, do what we can to keep ourselves and our loved ones safe and healthy. If you don't have a primary care provider, please get one, develop a relationship with them, make sure you're getting everything you need, all the information you need, the appropriate screenings and vaccinations based on your age and risk factors. And let's try to eat a balanced diet, quit smoking, avoid alcohol, sugars, processed foods, and artificial ingredients. If you don't feel well, make sure you get your rest. Otherwise, get some regular physical activity, get some fresh air, manage those stress levels, and get a good night's sleep. This concludes today's People's Health Briefing. Thank you so much for joining us, and we'll see you next Tuesday at 10 a.m.